molds are going to be eukaryotic organisms. So like we are, they'll built more like us. And they're a little different. They're more like plants in that they have a cell wall. So there's some different structures there. But the reason that becomes important, especially when you talk about treatment, is that with bacteria, the antibacterials that we use typically target prokaryotic structures, things that prokaryotic organisms have that we don't. So there's really, fairly relatively low toxicity. You can shoot for peptidoglycan, we don't have it. You can shoot for 70S ribosomes, we don't have those. So they don't really affect us too much. Once you start looking at eukaryotic structures, then you got to think about things that we have. And there can be some cross reaction there, some cross toxicity. Now, fortunately, fungi, yeast and molds have some structures that we don't have. So we're going to be able to target those. So it does, there is a little bit of a difficulty in treating those, but not quite as much as you would think. Now, this virulence thing, I didn't know how to really point this out. Virulence versus virulence with a question mark. But my reason for doing this is that the bacteria we think about can be highly virulent organisms. They can take healthy people and make them really sick. I don't want to diss the yeast. I don't want to disrespect them. I don't want to badmouth them and talk about how their infections are not really that important, because they are. But there is a lower level of virulence in the fungi. And so people typically have to have something wrong with them before they're going to get an infection with a yeast or mold. Now, that something wrong could be very minor. These are things that are listed as risk factors for yeast infections. And when they say risk factors, what they mean is that they say, for example, people who are hospitalized, people who are in the ICU have a greater risk of getting the yeast infection. You can't really talk about cause and effect there. You can't really say that because you went in the ICU, because you're in the ICU, you got a yeast infection. It's more, whatever the reason is that puts you in the ICU makes you more susceptible to a yeast infection. So the serious yeast infections tend to be things that people tend to be fairly sick to begin with something. Now, I put antibiotic use here. I think antibiotic use is one of the most important ones, because really your major host defense, the one first host defense that really matters a lot, is going to be your normal flora, the normal bacteria that are living there in your gut. And once these pharmacy people, start treating with antibacterials, that immediately reduces the competitiveness of that normal flora and makes you more susceptible to a yeast infection. So when I say you have to have some sort of compromise, I don't mean that you have to have some huge immunocompromise or something like that wrong. Sometimes it's fairly mild compromises that makes you more susceptible to a yeast infection. I wanted to show you a list of the most common yeasts that we get. So these are all the yeasts that we isolated here at Norton Healthcare in 2022. So on the left side, you can kind of see the list going down from the most common to the least common. I shouldn't say the least common. These are the top 10. And there are certainly several others that we got. So far and away, the most common one. Over half of all our isolates are the biggie, Candida albicans. And if you look down that list, you'll see every single one in the top 10 is some species that's in the genus Candida. Now, if we come over to the right side, those are just blood cultures only. And there's a little bit of a flip there, which is kind of interesting, because our number one isolate from blood cultures is Candida glabrata. Albicans is down in third place. In fact, I think it's amazing that we had 615 isolates of Candida albicans, but only 14 of those were from blood cultures. So you have a little bit of a different distribution when you're talking about blood cultures than you do with all specimen types. And I have to point this out. One of these days, I'm going to chat with you guys about taxonomy changes. But when we talk about the Candida species, they're changing names. So these are new names for these 4 species of Candida. There are lots and lots of others new names for yeast. We can get into the reasons for that. I just want to point it out here that we don't call it Candida glabrata anymore. Now it's Mucocutaneous glabrata. And we're trying to make this change, but of course, in my brain, we're all still thinking Candida glabrata. So I'm going to talk here a little bit about the biggies, which of course are the Candida species. But when I talk about Candida species, we're kind of lumping in those species of Candida that are not called something else. Okay, so Candida and Candida-like organisms. Most common by a long shot. All of them are normal flora in the human body. They like to live in the upper respiratory tract. They like to live in the genital tract. They live in the GI tract, and also on the skin. So you're going to find this in every person. It's normal flora. But they're typically there in pretty low numbers because they don't compete particularly well with the bacterial flora. The bacterial flora kind of tamps them down a little bit. The problem tends to come when that bacterial flora is diminished for some reason, or altered for some reason, and that lets these guys grow a little bit more. So when they overgrow is when you get problems. We've already talked about risk factors, but there are some specific risk factors there that are associated with candidal infection. A couple of different types of disease here. This is the most common by a long shot, a cutaneous disease or a mucocutaneous disease. These are really, really very common. I mean, how many infants get thrush? How many infants get diaper rash, like this one right up there on the right side? They're very common. So typically, I don't want to get too much into treatment, but fairly straightforward to treat, not particularly serious infections. But then you get to the invasive ones, and this is when we get much more worried about these. This diagram on the right kind of shows you can have situations where you have Candida colonizing the gut, normal flora there, but it can get in through the intestinal wall and get into the circulation. You can get from the skin into the circulation. This shows an IV catheter, which is one route to get in, but it could be other ways that it's getting in from there. You can get colonization that gets up through the urethra into the bladder, and then from there into the circulation. And once it's into the circulation, it can settle down in other spots. So these are some of the more common ones: endocarditis, osteomeningitis, endophthalmitis, some of the more common ones. But Candida is kind of like the Staph aureus of the yeast world, especially Candida albicans. You're never surprised to find it any place. It can settle down anywhere else and cause disease. Once it's in the bloodstream, it's a serious deal. Candidemia in the bloodstream, 25,000 cases per year in the United States. This says, and all the stats you read say Candida albicans is still #1 nationally, but in some cases, like here, it is now Candida glabrata, Mucocutaneous glabrata. The all-cause mortality is about 25%. About 25% of people who have candidemia are going to pass away. Not necessarily from the candidal infection. Remember, there's going to be some underlying illness, some compromised state that is leading them to get the candidemia. So they may die with candidemia, not necessarily from candidemia. But every case adds significant hospitalization, significant healthcare costs. So this is when we're really concerned with these candidal organisms. I want to bring up about respiratory tract specimens because they are very, very commonly isolated from respiratory tract specimens, from sputum, from bronch, among the most common isolates that we see. Some people have said, you can look at it and say somewhere in the vicinity of 40, 50% of hospitalized patients are going to have Candida in a sputum specimen. But here are some quotes from this paper down here. True invasive Candida pneumonia is so rare in immunocompetent patients that its very existence is debated. Candida pneumonia is rare, if ever, it should be if ever present. And when it's detected in respiratory specimens, it's considered to be an innocent bystander. Generally speaking, when we get Candida from a respiratory specimen, we're not concerned about it. But there are studies that show people who have Candida in respiratory specimens do have higher morbidity and mortality. The possibility is that it may potentiate bacterial pneumonia. Somebody who's got strep pneumonia versus somebody who's got strep pneumo and also had Candida in their sputum, that person with the Candida is going to have lower chance of recovery from that. So it looks really like Candida colonization of the respiratory tract is really just a marker of disease severity. It's not so much that the Candida is causing these worse symptoms, worse outcomes, but that it is a marker of someone who's going to be at risk for worse outcomes. So in our place, when we isolate a yeast from a respiratory specimen, we don't name it. We don't tell you that it's Candida glabrata or that it's Candida krusei or something. We just call it yeast. And then we put the comment in that says non-cryptococcal yeast are extremely rare causes of respiratory tract infection, usually indicates contamination with upper respiratory flora. And then, of course, we want to let you call. If you decide otherwise, they can call us and we'll go ahead and work it up. We get very, very few requests to work up a yeast from a respiratory specimen. Now, one yeast you do care about in a respiratory specimen would be Cryptococcus neoformans, which is different. This is not a normal flora bug. This bug lives out in the dirt, in the soil. We think about it with bird droppings, it's your association with pigeons, for example, but it's not really so much that it hangs around birds. It's like if you mix bird poop with the soil, Cryptococcus just loves that. There's nothing like the mixture of dirt and bird poop. That's what they really, really love. So that's why it tends to be associated to some extent with bird droppings. You're going to breathe the bug in. And like we're talking about, you have to have some compromised state. Most people, we breathe this in fairly regularly and nothing really happens. But if somebody has a weakened immune system, that's where we're going to have a problem. There is some evidence that it's sort of like some other diseases that we think about, tuberculosis or herpes, where you get infected at one point and the bug just stays dormant. And then years down the road, when there's a weakened immune system, that's when it comes back out and starts causing infection. But there's also evidence that, it is transmitted and then bam, there you go. You have infection immediately. Starts off as a pulmonary infection, which oftentimes is going to be asymptomatic. Otherwise, your typical pulmonary type symptoms may come along. But from there, it can disseminate into the bloodstream and go to the central nervous system and cause cryptococcal meningitis or a cryptococcoma. This is a picture of Cryptococcus in a brain specimen. Nice, pretty yeast, variable sizes. They always come in these variable sizes. You got big ones, you got little ones, and this kind of zone around it, that's because of a big polysaccharide capsule that spreads around these cells. Now, there is another bug out there more recently seen, Cryptococcus gattii. Geographically, not quite as widespread as neoforman is. The worry about that one is you're more likely to see infection in immunocompetent people. We don't see Cryptococcus neoformans in immunocompetent people, but we do see gattii in immunocompetent people. And it causes a few little differences between the two of them. Nodules instead of a diffuse presentation. So you got to keep that one in mind as well. And then we come down to the big guy on the list these days, the one that we're all worried about, and that is Candida auris. Candida auris did not exist in our knowledge base, at least, until 2009, when it was isolated in Japan. Now, they've actually done a retrospective study which showed that it was actually around in 1996 in South Korea, but it really wasn't identified at that point as anything special. But now we have Candida auris in Japan, and from there, it has spread. The Japanese one is now called the East Asian clade. You can see these, you got these 4 clades, and the interesting thing about it is that these seemed to have derived independently. So you have this Candida auris that started in Japan. You have a Candida auris that started in South Africa, kind of independently of each other. And if you look at these, you know, I don't know how many times you read these genetic dendrograms here, but they're not very closely related to each other. They're very closely related within the clade, but the 4 different clades are not particularly related very much to each other, but they share all these same characteristics. Especially look at this South American clade is really quite different from the others. There is now a 5th clade, which has arisen right here in the Middle East. So there's a new clade for that. But you can see from this diagram, they've all infiltrated the United States. You know, different clades, more common in different areas here. I don't know why Indiana got the South African clade, but you can see all 4 clades are present in the United States. Now, it's come on fairly slowly until recently, perhaps. 2009 is when it showed up in Japan. The first case in the United States was in 2013. So these are the states here that had cases between 2013 and 2016. So we're going to go through the years here. Here's 2017. Okay, Indiana joins in. 2018, Illinois, Chicago, of course, is gone to red. Indiana doesn't have any there. 2020, still none in Kentucky. 2021, still none in Kentucky. Sorry, I'm looking at the wrong slide here. 2020, 2021, there is the first cases in Kentucky. That was when we had our first cases here. We had 2 cases here at Norton Healthcare in 2021. And then in 2022, Kentucky is getting a little darker and a lot more states are starting to have it. But you can still see in 2022 that there's a lot of states that have not had any Candida auris yet at all. It's certainly spreading. Now, why do we care about Candida auris? One thing is the drug resistances. Over 90% of isolates show resistance to the azoles, fluconazole, for example. You have some resistance to the echinocandins and a pretty sizable number that are going to be resistant to amphotericin. So a lot of resistance. More than 40% of them are multi-drug resistant. More than 40% are going to be resistant to at least 2 of these classes. And there have been some that have been resistant to all 3. Now, this is from 2017, so things may have gotten different a little bit since then. But the other issues, higher mortality. We talked about invasive candidemia at a mortality of 25%. With Candida auris, it's shooting anywhere from 30 up to 60% mortality. So there is more concern there. It's an infection control nightmare. This bug can survive on skin for a long time with no symptoms whatsoever. It hangs out there. And because asymptomatic individuals can have it on the skin for a long time, they can walk around contaminating the environment for a long time as well. And once it gets on those surfaces, it can stay on those surfaces for a long time. It's a fairly hardy bug and kind of withstand some of our treatments that we have. Most commonly, patients with long-term exposure to healthcare systems. So all the same people that you would think about as being more likely to have CRE or some of these other multi-drug resistant organisms, they're going to be the ones who are most likely going to have Candida auris as well. And from a lab perspective, we worry about it because it's difficult to identify. If you look at the traditional means of identifying yeast, those don't work for him. They're not going to be able to identify it that way. So really, from a practical standpoint, the only way to really identify it in a clinical laboratory will be if you have MALDI-TOF. Those laboratories that don't have MALDI are really going to have a very difficult time trying to identify it. So what can labs do? Of course, I'm a lab person. Okay, I'm sorry. We're going to have to move over to the lab side now a little bit. So what can labs do to help with this Candida auris situation. One is identify all your yeast isolates, especially if they're coming from invasive infections or if they're coming from respiratory sites. Now, I just told you, for example, that when we have a respiratory specimen, a yeast in a respiratory specimen, we don't identify it. Well, we actually do. We just don't report the name. So in our place, what we do is we identify every yeast we isolate. And then decide whether we're going to report it by name or not. And if it's Candida auris, of course, we'll report it by name. So this is not going to happen unless you have MALDI. If you have a laboratory that still depends on biochemical identification or morphological identification, it's going to be too difficult to make the identification. So you really would not practically be able to do this identification of all yeast isolates. All isolates of Candida auris get reported to infection control. All of them get susceptibility done, whether you do it in-house or whether you send it out, and all should be sent to the state laboratory for their use. The other thing you can do is admission surveillance testing on selective patients who come in with these risk factors for Candida auris colonization. Culture them right off the bat. Culture them. It's typically suggested to do the axilla and the groin. It is going to be done by culture. So you have those same problems as are you going to be able to make the identification or not? But it has to be done by culture at this point. Unless, I shouldn't say it has to be done by culture. There are PCR reagents available, but none of them are FDA cleared. I know several companies that make PCR instruments that have it on the drawing board. They expect it to be available next year or the year after that. So at some point here, within the next 12 to 24 months, we will have FDA cleared PCRs where you can do it for surveillance purposes and also hopefully for identification. But that's not really available now. You can do a PCR, but it's going to be a laboratory developed test. So that's a lot more work to do. So what we do to diagnose yeast infections in the laboratory is we just grow them. They're all going to grow on routine bacteriology cultures. You don't have to have a fungal culture to look for these yeasts. They're going to grow in a routine blood culture. They're going to grow in a routine respiratory culture or a routine wound culture. They will grow there just fine. It might be helpful if you suspect one of these to order a fungal culture if it's coming from a site that's heavily contaminated, because you don't want a situation where you have some yeast in there, but the bacteria overgrow them. So I'm not going to argue with anybody who wants to order a fungal culture, but generally speaking, it's not going to be necessary. On a bacteriology media, it's going to look pretty much like a bacterial colony. I want to show you a few pictures here. This one here in the upper right, there are a couple of colonies there of like a viridans strep, an alpha hemolytic bug right there. But you see these white colonies, and that colony right there is something different. But these white colonies here, you see how they've got these little extensions on it? That is classic for Candida albicans. So typically, when we see that kind of thing, we already pretty much know that it's Candida albicans. This one down here at the bottom, this is not a yeast. This is Enterococcus faecalis. So it kind of shows you that, the colonies there look fairly similar. And this one right here, this is a urine culture that has Clebnumo, these big colonies, and these smaller colonies, which look a whole lot like this Enterococcus faecalis, are actually Candida tropicalis. So if we were working that up, I would not look at that plate and say, oh, look, I got a Clebnumo and I got a yeast. We would have to do some further testing on that colony to see whether that was a yeast or not. But it's growing. It grows very well, no problems. This is just a screen here to show you. These are some of the traditional methods of doing yeast identification. This upper left is a germ tube test. You mix it in some serum, let it sit for a couple hours, and it will make these germ tubes. We have always said Candida albicans is the only yeast that's going to make germ tubes. That's not exactly the case. Candida dublinensis also does it. So those two can be very hard to distinguish. There's a lot of laboratories. We're one of them, which for years did identification of Candida albicans with germ tubes. And then when we got moldy, realized that somewhere around, I don't know, 10% of our Candida albicans were actually Candida dublinensis. This is cornmeal agar, an absolutely horrendous way of doing identification, but that's what people had to do. You had to be able to look at that and tell what yeast it was. And honestly, I have no idea. Biochemical testing, either with this kind of strip down here in the bottom left, that's what we still use if we need to occasionally, or an automated system. This is a microscan yeast ID cartridge. Vitec also has those. So these are the ways you do it. And these are the ways that I say, none of these are going to work for Candida auris. None of those will work for Candida auris. Now, you can go to this, chrome agar. Chrome agars are always kind of cool. This is a medium that you streak the specimen on. It is very selective. So really, you're only going to get yeast growing on this at all. And different species of yeast will make different color colonies. So this green over here is Candida albicans. The purple is Candida tropicalis. I think this is a trichosporin down here. This one here is Candida krusei, the big pink fluffy things. The problem with this for auris is that auris is not really something that's going to give you a specific color. These colonies right here on the upper right, that is a Candida auris strain. And down here at the bottom, you see a Candida auris mixed with a Candida albicans. But you can't identify auris this way. You can only look and say, I've got a yeast growing. I need to go farther with this to see which one it is. I mean, I can look at this and say, these ones down here, that's not Candida auris. He's not going to be green. But this one here could be. So these days, simple and easy, what we're going to do to identify yeast is you get it growing on the plate and you put it on Maldi. Maldi does a good job. Maldi has gotten better. The early days of Maldi, which is about 10 years ago now, it had trouble with yeast. It still does not do yeast quite as well as it does bacteria, but I would say 99% of our yeast we can isolate in 30 minutes using Maldi. Works very well for Candida auris. So lastly, let me end up with susceptibility testing the yeast. The national guidelines do say that if you isolated yeast from a normally sterile site, so if you were to get it from a blood culture, or if you were to sort of get it from a spinal fluid, or some tissue specimen collected from an internal organ or something like that, you should have full susceptibility testing done on that organism. Some labs do it in-house. There are various ways that you can go about doing it. It's not as simple, it's not as straightforward as doing bacterial susceptibility. There's a little bit more work that's involved, a little bit more interpretation that's involved, but it can be done. Most laboratories are going to say certain yeast isolates we will send out to a reference laboratory for susceptibility testing, which is what we do here. And you do have some yeast that you really have some concerns about. Obviously, Candida auris, you're worried about resistance to everything. But the biggies that come up would be labrata and what used to be Candida krusei, and now, just for the fun of it, they're now calling it Pichia kudryavzevii, because it just rolls off the tongue. We worry about fluconazole with that one. But I'm going to leave that because Sarah is biting at the bit to talk about that next week. So that will be next week's topic. So I'm going to leave it right there and see if anybody's got any questions.
Hey, Alan, it's Matt.
Yeah.
Hey, I had a question. I've always been kind of fuzzy about Hyphae and pseudo Hyphae.
Yeah.
So I was wondering, sometimes we see that reported out on like cultures. I was wondering, how should we be interpreting that? Does that like help us identify a certain Candida over another, or does that lean towards virulence, like the idea that it's in a vegetative state or so on?
Well, if you want to get into virulence, it probably does make a difference virulence-wise in vivo. Supposedly going to a pseudo-Hyphae producing state actually supposedly enhances invasiveness. But what we're looking for, a yeast cell is this round thing. It might show some budding, okay? Pseudo-Hyphae is basically where there's an extension, but there's constrictions at it's like a chain of buds is basically what it is. all the Candida, let me say, I'm going to quote, I'm doing air quotes. I don't have my camera on, but I'm doing air quotes. All the Candida really produce pseudohyphae to some extent. Glabrata does not. So if we see that, we know it's not glabrata. If we see that, Cryptococcus does not produce those. So when we see pseudohyphae, you're pretty thinking you got some Candida species here. True hyphae is going to be more the molds that do that. There are a few yeast. Candida albicans occasionally will do that. But there you're talking about a couple of other less commonly isolated yeasts that will do that. So yeah, if you had a respiratory specimen or if you had a gram stain of anything and it said budding yeast with pseudohyphae, what that's pretty much telling you is that it looks like a Candida, but it's not a glabrata. It's not a Cryptococcus.
Okay. So true hyphae, think more mold.
Yeah.
Pseudohyphae, think Candida, but not glabrata or Cryptococcus. Right. Okay.
If it's just plain budding yeast, you're not really ruling out any of the yeast.
Okay. And then potentially more pathogenic if I guess
potentially in vivo. Yeah. How that really corresponds to what we see in the gram stain might be a different issue.
Okay. Cool. Thank you.
Yeah.
Hey, Alan.
Hey.
This is Sarah. I got another question. Do you mind just sharing your thoughts on the T2 Candida panel?
Okay. So for those of you who don't know what T2 is a lab test that I can't really explain it very well here. It involves molecular and also like nuclear magnetic resonance or something like that. The idea is that you can detect organisms in a blood specimen without doing the culture. So you can collect the blood. You wouldn't send us a blood culture bottle. You'd send us like an EDTA tube of blood, and we could do it directly on that. I say we, but we do not do this test, so don't send it to us. The idea is detect a bug in a blood specimen without having to culture it at all. So that's great. The first one that they came out with was for Candida, and it would detect a few different Candida species, and it would not necessarily identify them by name, but it lets you put it into different classes where you can say, I think this is going to be fluconazole susceptible. This one's definitely going to be fluconazole resistant. It's a very expensive test. I mean, if I look at it, I say, the cost is up $400 or $500 to do. It may have changed. That's the last time I was quoted a price. It was up around that range. So it's pretty expensive to do. You can look at it and say, it would be a great test to do on a patient where we have a high suspicion for candidemia. I don't want to do it on patients where we do not really have a high suspicion, because I don't really want to do this on 20, 30 patients in order to identify the one that does have it. Okay, that would get to be really pricey. You're going to do a blood culture anyway. So this bug is going to grow. Let's just say it takes this bug 48 hours to grow in a blood culture. You're going to know you have yeast in 48 hours. 24 hours later, we'll know who it is. So it does allow you to cut back. It would allow you to perhaps say, okay, I'm going to cut back from anidulafungin to fluconazole a few days earlier. I hate to kind of sound like it's all money, but that's how much money are you going to do 20 patients in order to save 2 days of anidulafungin? The other issue I kind of look at is if you have a patient who really you do have a high suspicion for candidemia, and you do the T2, and it does not detect one of these 4 or 5 species of Candida, is that enough information for you to feel comfortable withholding antifungals at all? So it's great if you could say, I'm going to de-escalate or stop antifungals on the basis of the T2. But if I'm choosing wisely who gets the test, then I'm in a situation where say I have a high suspicion for candidemia. Am I going to drop until we get actually a negative blood culture? So it's a very tight line between wasting money, wasting resources, and hitting that sweet spot where you're going to be able to quickly, affect patient care.
Yeah, that's it. Interesting to hear you say. I mean, from my perspective, clinically, I have never had much of an idea of how to position it in a useful way, that you're actually probably making good use of resources and going to affect clinical care. Like, to your point, do you trust it for everything? And most of the real world data looks like it has a high concordance, but I know of one report out there that was out of Indiana University that they had some discordance where the T2 was also missing things that it shouldn't have. So like Candida albicans and all that, that it asked the MSL about it and they weren't able to, which I mean, it's another institution. So there might've been some like professionals and proprietary stuff, but give us like a great answer as to maybe what was going wrong on an operational side, because that does, give me some pause to say, you're supposed to really be able to trust this. And if you can't, then it's not doing what it's intended to do from an antimicrobial stewardship standpoint.
Well, obviously it's not going to be perfect,
Yeah.
And, when we talk about sensitivity, you can say that should be much more sensitive than culture, but culture is a weird little thing because you look at it and say, no, theoretically, if you got one cell of Candida albicans in that blood culture bottle, it's going to grow. Okay. Now, it may not, because we sit there and tell people you got to put in high enough volume and blah, 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 all that kind of good stuff. But, you're talking about doing this weird little thing, putting in a little bit of volume of that blood into this machine and having it be able to take 1 or 2, 3 cells. That's a big ask. So, yeah, I know. I'm like, I don't know. It's be hard, like you said, hard to position it in the right spot of exactly how to use it. Okay, I guess that's it. And Sarah, you're on next week to finish up. So everybody have a good week.
Thank you, Dr. Junkins.
All right, thanks.